With this approach, it's so minimally invasive that that becomes much less of an issue. So these are the two percutaneous cardiac valves that exist in the world. They're supplied by two different companies. And I'm happy to tell you that UHN currently has the largest armamentarium of percutaneous valves for the aortic, mitral, and pulmonary position of any hospital in the world. So this is what the procedure looks like. The blue line shows a catheter going up from the groin and into the heart, and you can see the actual size of the valve once it's been deployed on this picture. This is schematically what happens. You put the valve across the aortic valve, and this is all done under X-ray imaging, and you can't be 1 millimeter off. This has to be precise. So this is where the imaging in the MPOR is going to make this procedure much, much more accurate. Once the device is in place, you inflate the balloon, and it sits in the aortic valve position, squishing the old valve out of the way and putting in a new valve. And this is just up close what it looks like putting the balloon in. You pre-dilate so that the valve is open. Then you put in the device, and the D panel shows the device deployed. So this is where we used to do this. This is in the cardiac cath lab. I'm sure that this picture was taken to maximize the clutter, but nonetheless, this is where we were doing this procedure. Not a lot of room. There is a patient under there somewhere. This is a video clip of a percutaneous valve being deployed. The large black tube is an ultrasound device that's positioned just behind the heart in the esophagus. There you just saw the valve being opened. Now the catheter is being moved down out of the way, and you're going to see another catheter come into place. I'll tell you when it's there. Right there, that's to inject some dye. So some dye is going to be injected, and the heart should be pumping blood out. Now a little bit of dye refluxed back into the heart, so they waited just for a moment. This is actually happening in real time. And they took the device out completely, and now you're going to have another injection of dye, and you're going to see that none of the dye goes backwards into the heart, it only goes forwards. So thank you so much. So the valve has now been completely repaired. There's the percutaneous valve. And this is all done through a little incision in the groin rather than doing a sternotomy. So those are a couple of elective cases that we've done. I'm going to review some emergency cases where we think we can have actually an even greater impact by having access to intraoperative imaging and being able to do operations. So I'm going to show you an aneurysm repair, removal of clot from a leg artery, a fairly dramatic case of a young woman who was pregnant and had an acute aortic valve problem, and what we do with patients that come to the emergency room with severe chest pain. So this is what an aneurysm looks like before rupture. There's the aneurysm. There's not a lot separating the wall of the aneurysm from the outside, and if it breaks here, about half of patients are going to die in 2 minutes. This is what it looks like after a rupture. Happens to be the same patient, and there's no contrast here, so you don't see this white, but all this is blood leaking out of the aorta. It's being contained here. As soon as this ruptures in front, the patient's going to die. So, as I said, death in minutes to hours after rupture. So we took this patient to the operating room. This is, again, a combined approach between a vascular radiologist, Dr. Tan, who's the head of interventional, my partner, Dr. Lindsay. This is a vascular surgery trainee, and there's a radiology trainee together. And I like this picture because Dr. Lindsay is looking at the monitor here, and Dr. Tan is looking at the monitor there. Before we had this room, we only had one monitor, so depending on which side of the table you're on, you're either looking at it like this, or you're operating and trying to look at it like that, which is not good for your long-term neck health. So that's a picture where we're nearly completed, and that gives you a feel for what the room is like. It's dark because you want to be able to see the screens well, so we're frequently turning the lights off, turning the lights back on in the room. This shows the same aneurysm with a stent graft in it. If you look, you can see, okay, the laser gods are not with me today because this is going in and out. You can see that there's a little bit of stippling here. This is the stent graft. Now there's no more blood going through the aneurysm, it's only going through the graft. And this is a three-dimensional reconstruction of what the graft looks like. The little bit of red that you see over here is from the previous leakage. This patient was completely stable, and the ability to put the stent graft exactly where you want to enables, with the imaging that we have, enables very precise delivery. This patient went home on the 4th postoperative day. Usually after a ruptured aneurysm, if you live, it's many, many weeks in hospital and months to get over this. So as I've tried to emphasize, we think we've created an environment that's uniquely able to deliver multidisciplinary patient care. There's 2 current collaborations that are mature. The first is between vascular surgery and medical imaging. We do all the endovascular aneurysm cases together. And the second is between cardiac surgery, interventional cardiology and vascular surgery, where all of the percutaneous, which means through the groin, or transapical, which means through a little incision in the chest, valve repairs are done. So this is the quintessential place at Toronto General Hospital where multidisciplinary teams work together. The next patient was 33 weeks pregnant and presented to the hospital with severe shortness of breath and was found to have critical aortic stenosis. This was so bad that this patient was short of breath just lying in bed, and it was felt that either she or the baby or both would not survive a cesarean section. This patient arose at Mount Sinai. There was a tremendous, very rapid planning process that went on to get this patient across the street to Toronto General, to the multi-purpose OR, and this is who was included in this team: cardiology, obstetrics, a neonatal care transport team, cardiac surgery, perfusion, vascular surgery, anesthesia, respiratory therapy, medical imaging, and most importantly, nursing from both sites. Any member of this team isn't there, this cannot happen. So this is a picture from this case, and this is who is present. So you can see the anesthesiologist is watching the case. 2 cardiologists, including Dr. Horlick, who's the head of the valve program, is getting ready to put a balloon inside this patient's aorta. Patient is lying over here. That's vascular surgery fellow, and that's the obstetrician, Dr. Surmer. So this room is big enough that we had the patient on one end. This is all the stuff that you need to do an operation to deliver the baby, or to go on pump if you have to, because we planned that if the patient crashed, we would rapidly go on pump and try and save her life. This is the picture that I showed you intraoperatively. This is the obstetricians after the valve has been deployed, after the valve has been plastied. The obstetricians are reading the monitor to see how the baby was doing, and they decide to do an emergency cesarean section at that time because the baby wasn't doing well. And this is the neonatal transport team in a room adjacent to the multipurpose OR where we had a neonatal ICU set up. So the bottom line, healthy baby, healthy mother, both discharged from hospital, follow up by cardiology. Just a terrific outcome. And this could not have happened if we didn't have an environment that enabled multidisciplinary care and OR teams that know how to coordinate, having multiple services working together for the purpose of one patient. This is the best example you're going to see of patient-centered care that we talk about all the time. So this is another example, a patient who presented to the emergency room with a painful white foot. That generally means that the circulation to the foot has been compromised. There were no pulses. She couldn't move or feel her foot. And what we used to do with this type of patient would be take them to the operating room and try and figure it out without imaging, because you didn't have the imaging available. Today, we take the person to the multipurpose OR. The problem leg is this side. We put a catheter on this side in the groin, slide it up to here, and shoot a picture. You may be just able to make out the catheter right there, and you don't have to be a vascular surgeon to figure out that the artery goes to here and then acutely stops. So once we were armed with this information, we knew exactly where the problem was. We operated on the groin. You can see the blockage there. We operated on the groin, and this is an intraoperative picture of doing the groin procedure. And again, teams, vascular interventional radiologist, vascular surgery trainee. So Dr. Snyderman is teaching Dr. Maloney how to do this procedure. I can tell you that in other hospitals in Ontario, Dr. Snyderman isn't talking to Dr. Maloney because these 2 groups of physicians, vascular radiologists and vascular surgeons, are fighting over who's going to do these cases. Not here. We work together. So this is the picture before the clot was taken out, and this is the picture after the clot is taken out. And you can see no blood flow here and blood flow over there. the marriage of intraoperative imaging and operative surgery. One of the most common problems that we face is patients that present to the emergency room with chest pain, because the patients don't come all the time and necessarily have it easy to make it easy to diagnose. Are they having a heart attack? Do they have a torn aorta or a dissection? Do they have an aneurysm in the chest that's ruptured? Or have they had a blood clot come off from their legs and go into their lungs? All, each and of their own, lethal conditions. So before we had a multipurpose OR, this is what would happen. The patient would be in the emergency room, and if you thought it was a heart attack, they might go to the cath lab. Or if you weren't sure, they might go to the CAT scanner in the radiology department. Or they might go to the angio suite to have an angiogram to try and figure it out. And then they go to the operating room for definitive therapy. So imagine wheeling a patient around the hospital in extremis who is dying, and you're going from one imaging modality to the other. Not terribly effective.